today.
All right, we're going to pick up where we left off, and we're going to do a little bit more of those questions that help us separate the fact from fear. So let's move on with the next one now. How accurate are those so-called no-touch thermometers? Now, remember, they're going to be using these to screen for fever as people are coming routed through, because you can't fly directly from West Africa to the United States, but routed through some of our partner airports like Brussels and Charles de Gaulle and France and others. And so when they hit the U.S. soil, our people at our airports, 5, 6 of them now specified, Dr. Samadi, they're going to take temperatures. But do they have to touch people? I mean, I'm just wondering, how accurate will it be?
This is an infrared, actually, thermometer, and also it's also dependent to the expertise. We have to make sure that the TSA is trained in this to get it right, and we're turning like TSAs into doctors today, so that's not easy. But also sometimes they're not 100% accurate. Some of these thermometers may read the wrong number. I also want people to know about this change in temperature. The fever about a month ago was 101.5, and now they brought it down to 100.4.
You mean the temperature that they're watching for?
That's the definition of fever today, is around 100.4, and that's totally changed.
You know, why is that important?
Well, they're basically lowering the fever, so in order to be able to catch some of these patients that may have the Ebola virus. Because one of the first symptoms of the virus, Harris, as you know, is fever, then follows with muscle pain and headache and everything else.
Right, and in fact, we have a diagram of that we're going to pop up on the screen because, you know, in terms of separating fact from fiction, it helps to know exactly what people are going to feel as they come up. In the different areas of the body. If they pop that up, we'll look at it. But meanwhile, you know, what if somebody's taken like Tylenol or something? I mean, I always wonder, you know, with this nurse who called the CDC to see if she should get on the flight to come home from Cleveland to Dallas, that nurse who had treated Thomas Duncan, decided to fly to Ohio to go plan her wedding and then got sick. She calls and she says, look, I've got a fever of 99.5. Well, if you take something, that brings your fever down if it's working within range. So now you're testing people who possibly are medicated.
Right. So there are two ways to look at this. You can talk about the personal responsibility of the nurse. She should have probably known better not to get in. But you can also argue that she called CDC, and that's where the public trust is sinking and going down. Because if you're going to call CDC, somebody who has been exposed to Mr. Duncan and now has some fever, not feeling well, just keep her off the public scene. And that's what they should have done. Instead, she went in with fever of 99.5, and she landed on the other side with 100.3, which, by the way, both fevers are under the radar. So that tells you that fever is not the best screening test, as we've seen, whether you take some Tylenol or some medication that can lower it.
Or your body just happens to be fluctuating a little bit. So you get off the plane like she did with 100.3, even under the new guidelines that you're getting snippets of now. They still haven't rolled out the whole thing. That's what we've been waiting for a few days.
That's true.
Even under the new guidelines, they wouldn't have caught this.
And that's part of the problem, because you may have the muscle pain, you may have other symptoms, and maybe we can show the diagram.
Yeah, let's do it. Okay, so it takes a lot to be able to pick these things up. Let's take a closer look at what's happening to the body as the virus makes its way. The early symptoms don't typically begin to show up until a little bit more than a week after exposure, and those will be coded in blue here. Doctor, go ahead. You get a headache, muscle pain?
That's what you see, Harris. In the first week or so, you would see headache, you see muscle pain, you would see sore throat. And then as time goes on, that's when you're going to get into vomiting, diarrhea. These are projectile vomiting. That's where the viral load starts to build up and the patient gets very sick, abdominal pain. And then finally you get to stages where things are almost irreversible, kidney failure, liver failure. And that's when all the coagulation and bleeding factors kind of get washed out, and the patient starts to bleed from their eyes, from internal organs. And that's when, unfortunately, some of the nurses are exposed to some of this body fluid, and it's dangerous.
You know, as you're talking about this, it brings to mind what people in Ohio and Dallas must have been going through, just wondering, you know, if we're going to be tasked with looking for this stuff on our own, what do we do? Let's bring in Dr. Michael Anderson. He is the Chief Medical Officer at Cleveland University Hospital's Case Medical Center. Dr. Anderson, good to see you. You and I have talked throughout this thing over the last couple of weeks. And as you know, I've got Dr. David Samadi on set with me. You know, to keep people calm, I would imagine in your area of Ohio, you've had to have a lot of conversations with the medical staff that you lead. What have you been able to tell them?
we really have had a lot of conversations both with the medical staff, the nursing staff, and quite frankly with the general public. Number one, that we believe the chances of us getting a case of Ebola is still very, very low. We believe the people that came in contact with the nurse when she was in Northeast Ohio is a finite number, and that the contact would probably not lead to Ebola. Having said that, we have to prepare. We have to be ready to screen these patients, to isolate these patients, and to care for these patients. So we really, since that news hit last week, have ramped up our plans big time.
Dr. Anderson, you know, Dr. Samadi has just brought up a really big, important point about screening at the airports, and that fever may not be the best way. So what are our options at this point? If we're going to continue to let flights route through different countries to come here, what are our options to finding it before it would spread?
Dr. Samadi's brought up a couple of good points I'd like to highlight. First and foremost is we continually assess how we're screening people coming to this country, and are they at risk for spreading Ebola virus. I agree. Is it temperature? Is it a more thorough questionnaire? Is it a more thorough medical screening? There's obviously a lot of operational issues that would go with that. And if we come back to it, I also agree wholeheartedly that, God forbid, we get a patient in Northeast Ohio, in any part of this country, I would agree with him wholeheartedly that first and foremost, the best place to care for those patients is one of those 4 centers across this country.
I know that there are those 4 centers, and that the CDC had first said that any hospital could handle this. But Dr. Samadi, you say that's not true.
Well, I think that's what I was going to ask Dr. Anderson and get your opinion on this. I mean, I've said that, you know, about a month ago, what we received were a bunch of emails and also encouraging nurses to see some videos to prepare themselves for this. And I know that you're running multi-hospitals in charge of a lot of patients out there. My idea was to basically create some treatment centers for Ebola virus, be able to triage them. Let me know exactly what's going on your end. Are you prepared, for example, if a patient walks in right now, granted that we would ask for the history, they came from Liberia, your suspicion of having this kind of Ebola virus is high, what precautions have put in place in the last couple of weeks to be able to triage and get them to the right place?
It's a great question. First and foremost, we're operating as a region, so all the major health systems in town are sitting down and making sure we're on the same page. We're sort of on the same sheet of music, if you will. And we've broken it down into 4 areas. First is identify. Use those screening tools and making sure that we're identifying high-risk patients. The second is isolating. If we think we have a high-risk patient, instantaneously putting them somewhere where we can isolate them. Third is very important, and we take what happened in Dallas to heart. We need to protect our people, and we are training with personal protective equipment. We are using the buddy system. We're using videos, all the things that my great colleagues have talked about. And then 4 is care. Can we get patients, God forbid, the low risk of getting one, but can we get these patients to the right center so they receive the best care? So those 4 highlights have really been what we've been drilling for the last, 7-10 days now.
All right. Real quickly, before we go to break, we're going to ask Dr. Anderson to stay with us beyond that point. But talk to me a little bit about people walking into the ER and why the flu shot right now is probably one of the most important times in our recent history to get one.
Well, this is an excellent point because as we see, all the symptoms that we just saw between Ebola and flu are very, very close.
Early on.
Early on. And if you're going to get a flu vaccine, this is the year to get it because it would reduce the number of visitors to our emergency room. It would basically take all the confusion, whether it's flu versus Ebola. The only major distinction between the two is the history of travel to those countries. But you want to make sure that, you know, if you get your vaccine, hopefully that would take a lot of load. Look at this. You have headache, muscle pain.
It's very similar to the flu, and you're going to hope and pray that people are honest about where they've been. Dr. Anderson, no doubt people have been walking into ERs, though, since the news of this nurse traveling from Dallas to Ohio. And what are you seeing?
We are seeing a lot of people that are concerned that they have some distance connection to the flight or a distant connection to a potential contact. So there's there's large numbers of worried people, if you will. What we've been telling people is the risk of getting Ebola is still very low. Here's the high-risk criteria. If you don't fit into one of those, it's the fall. You've got a fever. You're going to be fine. So a big part of this has really been just calming the folks in Northeast Ohio that most likely you don't have Ebola.
All right. Dr. Anderson, you're going to sit by. Dr. Samadi will tackle some questions that people have been sending on Twitter. And Dr. Anderson, you're very, very active on Twitter because I'm seeing your hospital system has put a lot out. A lot of people in Ohio have questions for you. So I'm going to let you guys take it over when we come back, so everybody sit tight. First, though, a cruise ship given the all clear after tests on a passenger have come back negative. Well, thank the good Lord for that. It was still a nice Vacation, though, for many passengers on board because they heard words like quarantine and Ebola. But now we're dialing it back. We're dialing it back with the fact that they have been